Good morning, everybody. Thank you. We have our two of our five fellows are speaking this morning. Matt Jacob Recker, a pediatric neurological surgery fellow, and Aria Jamshidi, who is a skull base and endoscopic fellow. Both are working extremely hard, doing a great job. I'll start off with Matt. Matt was an undergraduate at the University of Pittsburgh, where he graduated on the Dean's Honor and magna cum laude in neurosciences, chemistry, and economics. Went off to medical school in Philadelphia, where he earned his MD degree in short order after that. And he did his training with our colleagues at Buffalo, trained with Elad Levy and Renee Reynolds there. He's now he was an AOA. Both of these gentlemen are AOA. In addition, Matt, whose character is that of an Eagle Scout, was an Eagle Scout, in fact, and he's produced over 20 peer-reviewed publications, and he's doing a spectacular job as pediatric fellow and will join us as faculty. Matt is going to talk about his epilepsy work. So take it away, Matt. Thank you for being here, both.
Thank you, sir, for the introduction. Morning, everybody. Let me just get this fired up. Does it look like?
It looks
like we're good to go.
Yeah, I think so. Yeah, go ahead.
Okay. Morning. We're going to talk about intracranial neuromodulation epilepsy. It's a pediatric epilepsy, specifically as a topic that I'm interested in from a clinical perspective and moving forward, a research perspective. So I just want to talk about sort of where the field is at and give everybody a kind of catch everybody up on sort of what we're doing on the pediatric side here at Seattle Children's. Advance. So just some objectives which were sent out in the flyer. We're going to talk about modern applications of intracranial neuromodulation and pediatric epilepsy, discuss some of the challenges unique to the pediatric population, future directions, interesting research questions. So just by way of introduction, as we know, epilepsy impacts a lot of kids, about 1% of the global pediatric population. Drug-resistant epilepsy is defined as failure of adequate trials of two well-tolerated and appropriately chosen AEDs, either monotherapy or in combination. There are diminishing returns, which we know from the Quantum Brody study, which tells us that addition of extra seizure drugs doesn't always work. In fact, often doesn't. About 20 to 40% of children with recurrent seizures that are diagnosed with drug-resistant epilepsy these are the potential candidates for surgical intervention, the ones that we should be thinking about as neurosurgeons. And the overall mortality risk of epilepsy that is uncontrolled is about 0.5% per year. SUDEP is obviously a very high risk in the pediatric population with uncontrolled epilepsy. So just to give a framework, this out of a Lancet paper recently that just demonstrates sort of where neuromodulation fits into our paradigm. I would say that, resective surgery and potentially curative options are still first line after drug failure. But neuromodulation has become more and more utilized, and there's more and more data, especially in the pediatric population, for how this can help. But if there are, generally speaking, especially for focal epilepsies, resective options, ablative options, those things remain the mainstay, but neuromodulation falls in behind those. So what options do we have for neuromodulation? Vagus nerve stimulation is obviously very well described in the pediatric population. Today, we're going to mostly talk about RNS and DBS. There are several others in development that are not super widely clinically utilized, but potentially on the forefront, just to give you a sense of some of those by way of list. So what do these devices look like? So VNS implanted in the left chest, wrapped around the vagus nerve, offers stimulation, which the mechanisms are still poorly understood as much as we use the device, but essentially afferent projections back to the brainstem, thalami, cortex, decreases synchrony of network activity and modulates GABAergic function is sort of the basis of how we think it works. DBS, depending on your target, these are depth electrodes that stimulate different targets in the brain, but for epilepsy, ANT is the sort of classical or initially studied target. We know alters the PAPE circuit and default mode network, and interferes with synchronization of brain activity, and interference of the ANT and hippocampal associations are known to predict treatment response. RNS is a device that's implanted in the skull itself and stimulates either by way of depth electrode or cortical strip electrode, offers burst high-frequency stimulation, essentially is a response to seizure activity, and attempts to abort those seizures by stimulating. We'll talk about a little more about each of these devices as we go. Just a brief word on some definitions. So closed loop and open loop devices, just as categories. Open loop devices are defined as continuous therapy, which is delivered at pre-planned parameters, don't respond to patient-specific factors like VNS and DBS, whereas closed loop systems like RNS record a particular biomarker in the patient and respond accordingly, varying the simulation parameters, timing, strength, et cetera, based on patient recordings. So RNS, this is an FDA-approved device in patients 18 years and older since 2013. Pertinent to the pediatric world, the RESPONSE study is currently ongoing, enrolling age 12 to 17. But it's indicated for no more than 2 seizure foci by an on-label indication. For single unresectable foci, which can be eloquent, deep, or failed prior resections, bilateral foci, or 2 foci in a single hemisphere. You can use cortical strips or depth electrodes, as I sort of pointed out earlier. And targets for this that are on label include mesial temporal targets like the hippocampus, neocortical targets, including eloquent areas, and deep foci like periventricular nodular heterotopias and dysplasias. Thalamus we'll talk about a bit today, but that is technically off-label utilization of the device. So how does this work? The basis for RNS was based on an observation that after discharges can be aborted by electrical stimulation, which was noted during functional mapping in patients undergoing intracranial monitoring. So essentially, seizures are picked up, and then stimulation is used to sort of abort that seizure activity. Although this was the initial conception, it's now known by the really great work by a lot of different people, including Mark Richardson at Harvard, that have shown that it's really sort of plasticity or alteration, modulation of these neural networks over time, and not necessarily the immediate seizure abortion that is influencing these seizure networks and causing good outcomes, which is probably beyond the scope of what we can cover today. But just know that it's more than just a pacemaker, sort of a defibrillator for the brain sort of effect. So it detects seizure activity, responds with stimulation. And then the other benefit to RNS is that it's constantly monitoring ECOG, and so that can be used by the epileptologists and neurosurgeons in their decision-making for frequency, for understanding frequency, time, and location, et cetera, of seizure activity, and potentially impact further surgical decision-making. So what data do we have for RNS? The RNS pivotal trial is kind of the hallmark study that people point to, 191 patients that showed significant benefit in the stimulated group compared to the sham group. And that benefit was propagated over time out to 9 years in more recent papers that shows continued improvement, which is an important feature of this device. The seizure benefit improves over time the longer it's used, which again speaks to sort of this idea that you're modulating the network more so than just aborting the seizures. There is shown to be sustained benefit, improved quality of life, as well as decreased SUDEP risk compared to predefined comparative controls. So it works for focal epilepsy, RNS. But what about for generalized or regional epilepsies? You can only stimulate 2 places with RNS, and so for global networks, does it still work? Leaning on some of the data, which we'll talk about later, for DBS, for Lennox-Gastaut and otherwise, people started using RNS for thalamic targeting to stimulate the thalamus in epilepsy. So why the thalamus? Dating back to Penfield and Jasper's centroencephalic theories, we know that the thalamus has extensive and reciprocal connectivity with the cortex, and therefore is implicated in epilepsy networks. So some of the targets that we use are listed here: ANT, CM, and VM, and pulvinar, for RNS, as well as DBS, which we'll talk about again a little bit later. The ANT network, ANT stimulation, we know modulates the limbic and thalamocortical networks, and reduction in functional connectivity between the ANT nucleus and the hippocampus is known to show an effect in epilepsy. CM is extensively integrated in cortical and thalamic networks, modulates reticular formation and somatomotor cortices, and so again, heavily involved in epilepsy networks. Pulvinar is typically used for posterior quadrant epilepsies. We'll talk a little bit about less about that today. but just for general information and knowledge. So RNS for generalized and multifocal epilepsies, these are non-focal epilepsies. What data is there? What initially started as a lot of kind of case series has expanded into some meta-analyses and retrospective analyses, a bigger series. But essentially, it shows that there is some reasonable benefit. A number of these studies are showing 75 to 90% seizure reduction, greater than 50% seizure reduction in over 65% of patients at pretty good follow-ups. The Nautilus trial is currently ongoing, looking at thalamic RNS for idiopathic generalized epilepsy and over 12 years old, again, pertinent to the pediatric population. So what about the pediatric population? What do we know about the use of RNS in peds? Saadi Ghatan and his group published a series of 27 patients, which is one of the bigger case series that came out in the last 5 years, which showed a greater than 50% reduction or responder rate of 68%. But a lot of the data that we have is limited to sort of complication outcomes and those sort of things, which do appear to be comparable to adults. This is another 6 patients that showed 5 of 6 patients that had a good response with RNS. And again, this is just general use of RNS, not specific to the thalamus. This was a study of 35 patients, multi-center registry that looked at age down to 3, which is interesting, and showed reasonable outcomes data, but mostly just looking at safety profile, which showed that it appeared to be safe in the pediatric population. So what about thalamic RNS? So again, Saadi Ghatan and his group published a series of 2 patients with Lennox-Gastaut with excellent response to thalamic RNS. In Pittsburgh, Taylor Abel and his group have published a couple. This is an older case series, case report. Subsequent to that, I think they just published another 6 patients of thalamic RNS. And then this group with 14 patients. Essentially, this paper is just showing us that RNS works to record seizure activity within the thalamus, CM, ANT, and pulvinar. And so again, we're sort of building this repertoire of experience and nationally, internationally, and using this device not only for focal epilepsies, but also for thalamic stimulation in the pediatric population, and seems to have, in its early phase, good effect. So it's an overview of sort of where we're at with RNS. So what about DBS for epilepsy? Again, this is an open loop configuration of a device, at least as of now, although that's changing. DBS is FDA approved for epilepsy since 2018 with ANT thalamus as the target that's actually approved. Has a long track record for essential tremor and Parkinson's disease in the movement disorders world. The system uses depth electrodes only, so there's no option for cortical stimulation. So primarily used for thalamic stimulation in epilepsy. It's an open loop system, as I mentioned, as of now, although that is changing. Stimulation parameters can be adjusted with a transcutaneous programmer. So what data do we have for DBS in the epilepsy world? The Sante trial was sort of the big trial that led to FDA approval for ANT thalamus, which looked at partial seizures, including secondary generalization, which showed over 50% reduction in seizures in over 50% of patients. There were a couple complications. They note mood disorders, suicidality, and memory problems, although those are less reported in the pediatric world as complications. But did show good efficacy from a seizure perspective, and follow-up out to 5 years showed ongoing benefit in all groups of ANT thalamus DBS. So what about other targets? So CM thalamus we talked about earlier for RNS as well as pulvinar. These are also studied in the DBS world. Going back to the 1980s, Velasco's group had demonstrated CM thalamus as a reasonable target for generalized epilepsies and showed good effect. But fast forwarding, almost 40 years, the Kukier group described 20 patients with generalized epilepsy, particularly Lennox-Gastaut syndrome, with up to 80% responsivity to DBS to the thalamus. So really, some really good data in specific patients that CM thalamus tends to work very well for seizure control. There are a number of other groups subsequently that have published data in this space. There was a fairly large trial called the Estelle trial, or at least well-known trial, I would say, only 20 patients, which showed some seizure reduction with CM thalamus DBS, although it was not actually statistically significant, likely due to a lack of power. Again, this is in mostly the adult population, but electrographic seizures were significantly reduced between the stimulated group and the non-stimulated group, and family-reported epilepsy outcomes were better. So what about in children? What do we know about DBS for children? There are a number of, again, we're limited mostly to case reports and case series, some meta-analyses with limited granular data, but essentially showing that DBS can work for some patients with reasonable safety profile compared to adults. This is a paper familiar to probably a fair number of us on the call that looked at CM thalamus, Seattle Children's CM thalamus DBS, and showed a responder rate of 4 of 6 patients, defined as over 50% reduction in seizure activity. One patient was 96% seizure-free at 2 years out. So we have these two technologies. We have RNS, we have DBS for generalized epilepsies. And what do we know about their utilization in the pediatric population? How do we sort of choose between them? Well, we don't have a lot of good direct comparison data. There's a lot of participant heterogeneity in the studies that are out there, as well as sample heterogeneity. They're almost all retrospective study designs. There's treatment variability. So what target are you using? What are the parameters you're stimulating at? What's the follow-up like? All those things. There are a couple papers that have looked at this as a general review, so DBS versus RNS, which have shown similar safety profiles and overall similar outcomes. As as a general rule, seems like over half the patients that are getting stimulated have reasonable benefit in both technologies. What's important about this paper, this is overall DBS versus RNS. So it's a bit of apples to oranges because DBS can't be used for focal epilepsies or cortical stimulation. Only 3 patients in this study had RNS to the thalamus. And so again, a bit of apples to oranges, but just generally looking at the utilization of these devices in kids. This study was specific to thalamic neuromodulation, so a little bit more apples to apples. 88 patients of DBS and RNS all getting thalamic stimulation with a fair distribution of CM and ANT, although tends to favor CM a little bit more so, as you see in the upper right. DBS had a slightly higher response. It was not statistically significant, but trended towards DBS being slightly more efficacious. And there was no difference based on target, whether it was CM or ANT in outcomes. So just a brief table kind of comparing the two technologies. They're both MRI conditional, although RNS that was implanted before 2018 is not MRI compatible at all. The battery life for RNS is 4 to 8 years, whereas DBS is slightly shorter, except the rechargeable edition, which is out now, is actually slightly longer. Both require intensive follow-up. The RNS requires a lot of patient participation because the patient has to upload the data via Wi-Fi to the servers. So that is an extra sort of burden on the patient side. Ability to record ECOG is present in RNS. DBS not quite there yet. There is local field potential monitoring available in DBS, at least the Medtronic system now, but it's a little less established, especially in the epilepsy world. And adaptive sort of DBS is an emerging technology that may shift DBS more towards a closed loop paradigm. Bone thickness, especially in the pediatric world, you have to consider an RNS as it is implanted in the skull. So that is less of an issue for DBS. For battery changes, RNS, you have to open the scalp every time you do a battery change because it is implanted in the skull. That's particularly important for pediatric patients because if you implant an RNS in a 5-year-old, imagine how many iterations of that battery they're going to need over their lifetime. That's a lot of scalp surgery. And so DBS, you only have to open the chest pocket to change out a battery. With RNS, you can combine thalamic and cortical stimulation. There's a lot of data coming out now that may be better than purely thalamic stimulation, a combination of cortical and thalamic stimulation. So that's something that you don't have available in the DBS world. Both of them have shown decreased SUDEP rates with both technologies. So in summary, intracranial neuromodulation seems to have similar efficacy and safety in the pediatric population, although data is still lacking, that directly compares the modalities, but there is some really promising results. Clinical decision-making, specifically for thalamic stimulation, again, because that's really where it's more apples to apples, DBS versus RNS. Right now, what we're basing most of our decision-making on is the ability to upload data. So does the patient have access to good Wi-Fi and participation to upload the data through the handheld device to the servers? is there a local team, a neurologist, epileptologist that can manage RNS versus DBS in their local area? Obviously, in the WAMI region, we have patients that are not close to Seattle Children's that can come and have their care. And so you need a local team to sort of help manage those things. And then, of course, patient preference. Do they want a battery in the chest? Those sort of things are part of the discussion. So future directions, sort of where are we going? Almost all patients that are getting intracranial neuromodulation in the pediatric world already have VNS. And the reason for that is because the data isn't that much different. So greater than 50% of patients are responders. That's great, but that's pretty similar to what VNS offers a lot of these kids, depending on the etiology of their epilepsy. And so a lot of these kids will get VNS first, as it's a less invasive sort of procedure. But do we need to do that? Who are the patients that may respond to DBS versus RNS better than they would a VNS? So we can just sort of skip that step. We don't know yet. There's a lot of work being done that looks at network-oriented approach to neuromodulation as opposed to focal, seizure focus oriented approach. That's probably more than we can talk about today, but are there better imaging technologies and modalities that we can use to sort of better define what seizure networks look like? And in tandem with that, what is the role for thalamic sampling with SEEG, and how do we use that data to decide who would best benefit from an ANT or a CM thalamus stimulation? That is still an area of ongoing research. And so from a clinical standpoint, we need to expand our registries. There's a couple of multi-center groups that are working on establishing sort of prospective registries that Seattle Children's will be participating in to accumulate data in aggregate and try to answer some of these questions long term as far as who are the best patients for what type of stimulation and which may work better. Just to give a brief look at sort of our early data, we are compiling this for publication from not only this multi-center registry, but also Seattle Children's. We're hoping to work on this and get it out sort of ahead of the field. This is what our experience looks like in the DBS versus RNS world for thalamic. This is thalamic only neuromodulation. We're about 50-50, which I think is atypical for most centers, 50-50 RNS and DBS, which I think gives us a unique edge to talk about our experience and what we're doing. Almost all the patients have had a previous VNS, as I mentioned earlier. A lot of them have previous surgery, and we tend to be skewing towards the CM thalamus as our primary target, which I think is common in the pediatric population. So I hope that gives you a sense of sort of where the field is at and sort of what research ideas and things that we're thinking about at Seattle Children's and kind of the way forward. I want to thank everyone for your time, especially Dr. Rogeman, Dr. Goldstein, Dr. Buckley, the rest of the epilepsy team at Seattle Children's Hospital, of course, Dr. Ellenbogen and Dr. Lee for your excellent mentorship this year, and Dom Nistal, who's worked on, provided that data on the previous slide and is actively working on sort of some of these research projects. Love to open up for any questions. Thanks.
That was excellent, superb. I can see, everybody can see why we're taking him as our next partner. He's done a spectacular job. I do have one question. You're working on the mechanisms for both DBS and thalamic stimulation of how, I guess, does anybody know how they interfere with the seizure production? I mean, I guess that's what most of the research is about, the mechanism, correct?
Yeah, exactly. I mean, there are non-human studies sort of that are looking at what these networks are doing and sort of, more intensive electrocorticography and things. We don't know is, the bottom line. There's certainly a desynchronization of seizure networks that is brought on by chronic neuromodulation or neurostimulation. So, but the exact mechanisms are still very murky.
Thank you. Any other questions? We have one more.
I do. This is Jeff. Sorry to be off camera. I'm in transit. Matt, fantastic, and you dress up well, and thrilled you're joining. How long do you think it's going to take to really have the data that helps us understand, ages, targets, all this? Because it still seems very murky.
Yeah, it definitely is. I mean, as far as a precise time, in the next decade, could we have a better handle on this? I'm optimistic. That's, one of the things that I hope to think about in my early career is, how do we answer some of those questions? And in 10 years, that would be, I think, the goal. By the end of my career, hopefully we'll have a much better sense, but I think over the next decade or so, we'll have some of these answers.
Great. Any,
Question. This is Frank. Matt, excellent talk and very intriguing. I wonder if in all of these devices, the seizure detection algorithm is the same, because I think success is dependent on whatever you're using to detect the seizures and counter their occurrence.
Yeah, so the only device that we talked about today, at least, that is monitoring active ECOG is RNS, and that's, their proprietary technology for that. And so all that is standard amongst centers, as the device, has its own process for that. The DBS is interesting. People are looking at sort of local field potentials, and that is a completely different paradigm than how my understanding of how RNS works. And so, moving forward, how we utilize that as more of a closed loop paradigm for DBS comes about is going to be really interesting. I don't think anyone really knows how to use low field potential data in DBS for epilepsy. But comparing that back to our experience with RNS is going to be even more challenging, because they're sort of different different mechanisms, that you said, and the way that we interpret that data is going to be really challenging.
Yeah.
any other questions? All right. Thank you very much. That was great, Matt. All right. Without further ado, I want to introduce Aria Jamshidi. Dr. Jamshidi is from DC area. He went to George Washington undergraduate, and he received a degree in biology with honors, and his minor was religion. He then did an ERTA fellowship, and it's a fascinating fellowship. It's a great fellowship at NIH. You get to do research at some branch, and he did it at NINDS, and for 2 years, he was a research fellow at NIH, at NINDS, did that, and went off to George Washington University School of Medicine on the research track, and then did his residency at the University of Miami at Jackson Memorial. He also is AOA from medical school, elected AOA, and he has produced nearly 40 peer-reviewed publications, and he's doing, from all reports from Manny and Shake, doing a great job as a fellow. So thanks, Aria, for working with us and being here. We really appreciate it.
Yeah, thanks so much for having me. Thanks for the introduction. Just power these up. Okay, so today I'm going to go over the treatment strategies for small intracranicular vestibular schwannomas in young patients with good hearing. This is a controversial subject, which is why I decided to talk about it. Let's see, next slide. So just a brief introduction. Vestibular schwannomas, they typically are, benign neoplasms of Schwann cells of the vestibular component of the eighth nerve, and it's included a slide for like the junior residents. The typically Antony A, Antony B fibers that you see always come up on the boards. The prevalence of these schwannomas occur up to 1% of autopsy specimens in earlier studies, and 0.02% in a population-based study. I'll be referring a lot to this hearing level equivalencies, the Gardner-Robertson grading system, and also to the AAO HNS hearing system, as well as the pure tone averages when describing hearing preservation and hearing loss in patients with these intracranicular vestibular schwannomas. So just wanted to include that in the slide. Next slide. So in terms of the management of these tumors have always proved to be a vexing problem, both for neurosurgeons and neurotologists, specifically these intracranicular tumors in young patients less than 65 with preserved hearing. So I'll address 3 controversies. So we'll briefly discuss the natural history of these lesions to determine a baseline rate of hearing loss against which to measure interventions. We'll review the rates of hearing preservation and post-treatment complications, and whether there's a preference for surgery or radiation. And finally, discuss if there are any technical factors that increase the likelihood of hearing preservation during microsurgery for these small intracranicular tumors. So, what is the natural history of these tumors? Is upfront treatment mandatory? That's the first question we're going to pose. And any discussion of these tumors, we must first address the natural history of these lesions in terms of preservation of serviceable hearing, since hearing preservation for these patients is the most important outcome for these patients. Now, in terms of natural history, the best study regarding these small intracranial tumors comes from a Danish study. It's a registry of over 3,500 patients, looking at patients that were treated as single referral center, using a uniform approach, eliminating potential selection bias. So all these patients with small intracranial tumors with serviceable hearing were initially allocated to follow-up imaging and audiograms. And in their initial study, they looked at a mean follow-up of 4.6 years and found that 56% of patients had preserved word recognition scores and 32% had a preserved grade A hearing. Now, when they looked at those patients at 10-year follow-up, they observed a linear decline, which you can see in this table on the bottom right. And 17% of patients had preserved grade A hearing and 34% had preserved grade A or B hearing, with that stepwise decline over 10 years. While 42% had preserved word recognition scores and 58% had preserved word recognition scores of 1 and 2. So while the majority of these changes occurred within the first few years after diagnosis, the long-term series continue to document hearing loss throughout the follow-up period. So again, you see it stepwise decline year after year after year. So the Danish report raised an important question of whether patients with 100% word recognition score should be considered as a separate group altogether. Now, when evaluating this subgroup of patients, we see in this figure 7 here, they found that patients with 100% word recognition score at baseline, 89% of those maintain word recognition scores of grade 1 at 5 years, compared to 43% of patients with 90 to 99% word recognition scores. However, this pattern of excellent hearing preservation in 100% word recognition score patients has actually not been universally replicated in other studies, which is important to know. So in an extension to the 10-year follow-up study, 81% of patients with 100% word recognition score at the time of diagnosis maintained serviceable hearing, but only 22% of patients with 70 to 98% speech discrimination scores at diagnosis were able to do so. And it's important to note that these hearing outcomes were not related to the sublocalization within the canal or the tumor size at diagnosis. So I think in conclusion, based off these findings, while many patients with 100% word recognition score at diagnosis will maintain serviceable hearing at 10 years, some will still lose serviceable hearing, as outlined in this figure here. So for this reason, patients with 100% word recognition scores at diagnosis, should still be considered for intervention. Now, with respect to tumor growth, in the Danish series, 34% of their 200 patients had tumor growth at 5 years at an average rate of 111% per year, with 40% of growing tumors extending outside the meatus on last follow-up, which was more than the overall rate of meatal extension. So in this and other studies, evidence of a growing intracanalicular schwannoma should be an indication for intervention, because these patients have double the rate of hearing loss on pure tone audiograms compared to non-growing tumors. But even those patients with stable tumors exhibited a decline in hearing, and lack of tumor growth actually was not an independent predictor of serviceable hearing preservation. Now, in terms of watchful waiting, with all our patients, I think watchful waiting should be discussed as an option or treatment option with these patients, particularly those who are obviously, elderly or have multiple comorbidities and have an increased risk from general anesthesia. However, there's not sufficient evidence to recommend watchful waiting in our youngest patients with 100% word recognition scores at diagnosis, although these patients may take longer to exhibit a clinically relevant decline in hearing. And that's because of those patients that were watchful waited over 5 years in this study, only 9 to 14%, 14% of patients who had potentially serviceable hearing were able to maintain hearing after failure of watchful waiting. And this was compared to a group who underwent gamma knife radiosurgery. So in conclusion, in terms of natural history, young patients with sporadic small intracranial schwannomas with preserved hearing are likely to lose serviceable hearing, in their lifetime. So this data leads us to question the policy of upfront watchful waiting in young patients, especially if we can provide a treatment modality superior to the natural history of 17% grade A or 34% grade A or B hearing preservation over 10 years. And now this is particularly true for our youngest patients who have, lifespans of more than 40 years and are highly likely to lose their serviceable hearing in their affected year in their lifetime. So our next objective is to look at the evidence to support a preference of microsurgery versus radiation-based treatment. Now we'll go over the three predominant radiation treatment techniques in vestibular schwannomas, and those are intensity modulated radiation therapy delivered in several fractions, CyberKnife, and Gamma Knife. So in terms of radiation therapy vis-a-vis IMRT, it's been shown to have equivalent rates of hearing preservation as observation, as outlined in this Kaplan-Meier survival curve from this study by a French group, indicating that it doesn't play a role in hearing preservation for these lesions. However, there is the option of CyberKnife, which is preferred at some centers, and in a meta-analysis of 800 patients treated with CyberKnife, the overall rate of tumor control was 94%, with short-term hearing preservation 79%. The complication rates were quite low, with 2% rates of trigeminal neuropathy, facial nerve palsy, and brainstem toxicity. And in smaller tumors, there were higher rates of tumor control and short-term hearing preservation that were reported. However, it's important to recognize that neither IMRT or CyberKnife has substantial long-term follow-up compared to Gamma Knife, particularly when considering patients with small intracranial tumors. So our most robust data comes from, Gamma Knife radiosurgery, especially from, the group out of Pittsburgh. This was a study initially describing 96 patients followed over 42 months with small intracranial vestibular schwannomas, and they quoted that 61% of patients maintained grade A or B hearing over those 42 months with excellent rates of tumor control without any permanent cranial nerve deficits. Other reports have also documented hearing preservation rates ranging from 51 to 64% at 5 to 7 year follow-up. And then they highlight that a lower prescription dose of 11 gray has been shown suitable for tumor control, but unfortunately didn't demonstrate any superior hearing preservation outcomes despite the lower dose. And some studies also suggest that Gamma Knife in younger patients with intracranial tumors, which we're focusing on today, have improved rates of hearing control. But owing to the previously described effects of continued hearing loss after Gamma Knife, obviously further studies are going to be needed. In terms of 5-year follow-up, these were two interesting meta-analyses by Maniakis and Saliba that found that Gamma Knife had superior rates of hearing preservation compared to microsurgery and observation. But then again, this was at 5 years. Then in one series, directly comparing Gamma Knife and radiosurgery for hearing preservation, although it comprised predominantly of no intracranial tumors, Gamma Knife had superior rates of hearing preservation compared to microsurgery, so 86 versus 43% of serviceable hearing. And again, the major benefit of radiosurgery is obviously the low rate of facial or other cranial nerve palsies occurring in less than 1% of patients. However, since Gamma Knife doesn't guarantee lesion obliteration, it's conceivable that, these patients with several decades of life, with over 40 decades of life for young, less than, or in their 30s or 40s, will continue to have progressive hearing loss with longer follow-up. So until more data exists regarding hearing preservation after Gamma Knife, young patients with intact hearing opting for radiosurgery should really be counseled about their long-term risks of long-term hearing loss. Now we're going to delve into microsurgery in comparison to radiosurgery for hearing preservation. So the middle fossa craniotomy, which we often use for these types of lesions, was first described by House in 1961. The first major successful series was published in 1985 by Haynes and Levine, and they describe an immediate postoperative hearing preservation rate of 82%. And that's, the upfront risk you're taking after that initial surgery, as opposed to, the risk of, down the line of losing hearing over the next 10, 20, 30 years if you choose radiosurgery. Now, the largest study reporting hearing outcomes after middle fossa surgery for intracanalicular schwannomas was presented by Brackman, who found that 90% of patients had grade A or B hearing preoperatively, and 59% retained postoperative grade A or B hearing. Now, so initially, these, as we highlighted, these hearing preservation surgery for schwannomas described limited rates of long-term hearing preservation. But obviously, as you know, we got better with the surgery, and as the microscope continued to evolve, we got better and better with hearing preservation. This is again from 30 years ago, 1990, where Shelton described his results in a report of 25 patients with 8-year follow-up, and 56% of patients had worsened hearing postoperatively, and 60% of patients with excellent pre-op hearing had only serviceable postoperative hearing. So they concluded that even in patients who underwent hearing preservation surgery, a noticeable decrement in hearing can occur during long-term follow-up. But again, this was from 1990. More recent series suggests long-term hearing outcomes with the middle fossa craniotomy may be better than previously reported. And again, I think this is just kudos to our continued evolution of the field, and trying to fighting to achieve better results. So subsequent reports by Friedman found 70% of patients who had class A or B hearing postoperatively maintained their hearing at least 5 years of post-op follow-up. And Wang found that 95 of patients found that in 95 patients, 82% had initial hearing preservation. And of those with initial hearing preservation, 98% continued to have grade A or B hearing at 1 year, with that going down to 94% at 3 years and 84% at 5 years. Now, more recently, another series by Mazzoni et al. With 6 to 21 years of follow-up found that patients who had a class A or B hearing postoperatively, 87% remained at grade A or B hearing at last follow-up, which are excellent results. And these series suggest that long-term hearing preservation rates after microsurgery can truly range upwards of 70 to 87% with postoperative preserved hearing and more up-to-date series. So leading us to conclude that microsurgical hearing preservation may be more durable than radiosurgical hearing preservation in patients in long-term follow-up. I'd be remiss if I didn't mention facial nerve injury. That's obviously a major concern with microsurgery, depending on the center you're at and depending on your experience, with facial nerve injury rates occurring from 5 to 15%. This is just a table outlining some major studies and their rates of House-Brackman scores of 1 and 2, again ranging in like the low 90s. And I think facial nerve outcomes have been much more difficult to associate with a particular feature, mainly because most patients, like almost 95%, achieve satisfactory facial nerve function. Some negative prognostic factors involving microsurgery and facial nerve outcome include obviously larger tumors, tumors that have been previously radiated or have been operated on, and obviously if a patient has a preoperative deficit. So a further potential benefit of microsurgery I briefly want to touch on is the relief of vestibular dysfunction after eliminating the vestibular nerve, which obviously rarely occurs after radiosurgery. And many preoperative patients present with vertigo, which can be extremely disabling. And post-treatment vertigo is actually a major predictor of post-op disability, and often those patients aren't able to return to work and have lifelong dependency. So accordingly, patients who have severe vestibular symptoms and are young also may even be better candidates for microsurgery. And this is just a study by Theodopoulos kind of outlining their cure rates in terms of disequilibrium post-op through surgical intervention. So I think in terms of microsurgical resection conclusions, I think as we synthesize the data for young patients with small intracanalicular tumors and good hearing at high volume centers, I think microsurgery affords the best chance of lifelong hearing preservation. And while facial nerve preservation is generally good in microsurgical series, it is important to highlight that Gamma Knife is superior to microsurgery from a facial nerve preservation standpoint. And again, depending on the center you're at. And for some patients, this may be a deciding factor. And lastly, significant preoperative vestibular dysfunction is a relative indication for microsurgical resection. Now, lastly, I briefly just want to touch on the technical factors associated with successful hearing preservation. So, one key intraoperative factor that affects the success of hearing preservation is the adhesion between the tumor and the cochlear nerve. So this is a study by Takuzo Moriyama. This is at the Carolina Neuroscience Institute. He looked at a series of 63 intracanalicular vestibular schwannomas resected via the middle fossa approach for hearing preservation. And all patients without adhesions between the cochlear nerve and the tumor capsule actually maintained hearing, whereas only 2 out of 11 patients with adhesions had preserved hearing. So this intra-op finding, may obviously influence the surgeon's decision-making vis-a-vis the sometimes competing goals of facial nerve preservation and hearing preservation. In terms of other technical factors associated with hearing preservation, it makes it difficult because there are no randomized trials that exist due to a lack of clinical equipoise. And obviously, tumor location and pre-op hearing status may determine the preferred approach. However, it's important to highlight observational studies suggest an immediate follow-up rate of hearing preservation, 50% in this study of patients treated with retrosig for intracanalicular tumors, which is substantially lower than the reports from middle fossa that we reviewed in the previous section. So this suggests, and I think that if hearing preservation is to be attempted, a middle fossa craniotomy, specifically, for these patients, small intracanalicular tumors should be preferred over the retrosigmoid approach. However, obviously, in patients where hearing preservation is felt to be more difficult based on the patient's pre-op anatomy, obviously it should be based off the surgeon's discretion, and a retrosig approach can be reasonable. In terms of other prognostic factors or technical factors associated with hearing preservation, some studies have found, obviously, that patients that have better preoperative hearing were associated with higher rates of hearing preservation. And radiographically, patients without fundal extension were more likely to achieve hearing preservation than those with fundal extension. So this is like an example of that, representing a patient with fundal extension and without fundal extension. Again, closer to the cochlea, the harder it is going to be to preserve hearing. And finally, other studies have found that patients with small tumors originating from the superior vestibular nerve were actually more likely to achieve hearing preservation compared to those with inferior vestibular nerve originating tumors. And that's a direct result of the adjacency of the inferior vestibular nerve to the cochlear nerve when you think about, Bill's bar and the vertical crest. And obviously the dissection of the tumor can not only directly injure the cochlear nerve when it's originating from the inferior vestibular nerve, but also can potentially compromise the nearby vascular supply. So in conclusion, natural history of untreated small intracanalicular schwannomas is highly unfavorable, with many patients eventually losing hearing on long-term follow-up in their lifetime. So I think accordingly, early treatment should be recommended for young patients with vestibular schwannomas and preserved hearing. And now, while this controversy is not completely resolved, I think initial data appears to favor microsurgery for long-term hearing preservation, especially at high-volume centers. And, obviously radiosurgery does remain an option, particularly for those patients who choose a lower risk of facial nerve deficits at the potential expense of decreased hearing preservation. And when managing intracranial schwannomas by observation, any decrease in hearing or tumor growth should all be an indication to consider treatment. Thank you so much for your attention, and I'll be happy to address any questions if you have them.
Great. Thank you. Go ahead. Whoever's Steve Haynes, Dr. Haynes.
Dr. Shaker.
Oh, but he looks like Dr. Haynes.
Yeah, Shaker, I get to go first.
Oh,
I'm older.
Okay.
Thanks very much. That was a great summary, particularly since it included citing our paper. And essentially the long-term results are very reassuring because it's pretty much what we thought we were seeing over time. In our long-term follow-up, what we finally concluded was that the patients in whom we were able to preserve hearing basically returned to the natural history of hearing,
Right.
of normal hearing, and followed a gradual decline in hearing with age that was
Right.
parallel to
Right.
the operated patient. So it's actually been a very nice, very satisfying thing to see this hold up after all this time.
Yeah, absolutely. No, thanks for publishing that and allowing me to cite it.
All right, Dr. Shaker,
So first of all, I wanted to thank Dr. Aria Jamshidi for his service and his work. Of course, we haven't given him the graduation certificate yet, but he's been doing a great job. Also want to mention that he's comes from a family of neurosurgeons. His dad was a trainee of Dr. Hugo Risley and was in the faculty at UW, and his brother is probably even better known. He's a neurosurgeon practicing in LA. So a couple of comments. One is that I think you did a great job with the analysis of the data. The intracanalicular tumors, by and large, are predominantly seen by ENT surgeons, people who have audiology clinics. With one exception, the group being those that get scanned for some reason and incidental tumors are discovered and then they get referred to neurosurgery. So most of the time, the diagnosis is made by neurotology, which has an influence on the treatment, because neurotologists, by and large, like the middle fossa and the translab approach. I don't like the middle fossa approach because it's technically a little more challenging for the ENT people who do the exposure. There's a higher risk of facial injury unless it's a very skilled person. You can generally achieve the equivalent exposure and much easier by using the retrosigmoid approach. But when you combine it with the endoscope, the concern always is the fundus, because you don't see the, you keep drilling, you may get into the posterior semicircular canal. So in such cases, you can enhance your approach by the use of the endoscope. One study we published when I was in Pittsburgh was we found there was a late decline of hearing in people who had been operated and tumor was removed. And we found that this was due to the placement of muscle graft on the IAC, the petrous bone. So we stopped doing that, for people with retrosigmoid and hearing preservation. And one thing that you mentioned is very, very important. That is, those who have the absence of extension to the fundus, or there's a bit of a CSF gap, by and large, they have a better hearing preservation. Now, with regard to the Gamma knife, the major concern was hearing loss, and the dose was reduced for that reason by Dr. Kanjioka and others. But it seems that despite the reduction of dose, the results have not really improved. I think in older people, definitely it's a watchful waiting is a good strategy. In young people, they should be given the option between microsurgery and radiosurgery. Hearing preservation surgery is technically more difficult than just standard vestibular schwannoma surgery. And as you mentioned, origin from superior vestibular nerve is better than inferior vestibular nerve, but also the vascular injury can sometimes, that is the internal artery that comes off the ICA, can be one of the problems. So you have to be very careful with that. And sometimes applying a little papaver at the end may also improve the data. In terms of monitoring, the direct recording from the 8th nerve is often better than just doing standard ABR or BSER, because it's very quick to give you the example or feedback.
All right. Thanks so much, Dr. Shaker, for those technical nuances. Those are always very helpful.